I asked Google's Notebook LM AI Duo to do a deep dive into the research on LDL targets. I was surprised by its response. Here it is.
Welcome to the Deep Dive. Today, we're really cutting through the noise on probably one of the most critical numbers for your long-term health, LDL cholesterol.
That's right. We've looked at the foundational studies, these huge meta-analyses, and what some leading health advocates are saying.
And the big question we're tackling, the one we want to nail down for you, is pretty simple. Should your LDL, that bad cholesterol, actually be below 70 milligrams per deciliter?
Yeah, and what we found in the source material, it really challenges what many people think of as normal, significantly.
See, that's a core conflict, isn't it? Many listeners might have heard from their doctor, 100, 130, you're fine.
Mm-hmm. Standard advice, often.
But the global science, built up over decades, seems to suggest that fine might actually be, well, dangerous. So we're here to get you that definitive answer on this sub-70 target, and crucially, why the evidence seems so strong.
And we can probably just jump straight to the main finding, really. The data is incredibly clear. It shows a linear relationship.
Linear, meaning?
Meaning the lower your LDL goes, the lower your cardiovascular risk.
Yeah.
There doesn't seem to be a point where it's too low for heart health. Lower is just better.
Okay, lower is better. That seems straightforward. So why 70? Why does that specific number, 70 mg/dL, keep cropping up as the sort of ceiling for optimal health?
Well, that's because the stakes are actually much broader than just, preventing death.
Right. Go on.
While these huge meta-analyses absolutely confirm that LDL is linearly tied to dying from cardiovascular disease, higher LDL, higher death risk. Simple as that. We really need to talk about quality of life.
Okay.
The sources we looked at really stress this point. High LDL doesn't just cut your life short. It often leads to decades of what they call crippling disabilities.
Like what specifically?
Things like strokes, heart failure, chronic chest pain, angina. And for a lot of people, avoiding years, maybe decades of severe disability, that's actually a much bigger motivator than just not dying.
I can see that. Yeah.
And getting that LDL below 70 is, well, it's central to achieving that kind of robust health span, not just lifespan.
That definitely reframes the goal. It's about optimizing your health span. Okay, so if that quality of life argument is so compelling, where did these aggressive targets come from originally? Let's look back at the research, right? The foundational stuff.
Absolutely. To really get why 70 is the target, you kind of have to look at three main pillars of evidence. First up is the observational data. What do naturally low-risk populations actually look like?
And that leads us to?
The 7-country study.
Right. Ancel Keys back in the 70s. This was the big global comparison, wasn't it? Diet and heart disease rates around the world.
Exactly. And what they found back then was, frankly, pretty shocking for the time.
Yeah.
Populations eating traditional diets, especially those low in saturated fat, think Crete, think rural Japan, they naturally had very low LDL levels.
Okay.
And the kicker, they experienced, and this is a quote, near zero heart attacks.
Near zero. The whole population.
Near zero. It was the first real indication that being almost immune to heart disease was actually possible, and it lined up directly with having low cholesterol.
Wow. It's still kind of hard to wrap your head around a whole country having near zero heart attacks. Did that finding land well? Was it immediately accepted?
Oh, it faced a lot of scrutiny. Huge pushback, actually, which is precisely why we needed those next two pillars of research to really solidify the link. People needed more, especially from domestic studies.
Right. You can't just rely on observations from Crete.
Exactly. The medical community needed confirmation from long-term studies closer to home. And that's where the classic U.S. study comes in, the Framingham Heart Study. Been running in Massachusetts since, 1948?
Still going, yeah. And Framingham basically set the American benchmark for risk, didn't it?
Pretty much. It was absolutely crucial in showing that within the U.S. population, as LDL levels went up, step by step, so did the risk of cardiovascular problems. It firmly connected those higher cholesterol numbers, the ones common in Western diets, to disease down the line.
Okay, so we've got Keys globally showing near zero risk is possible with low LDL. We've got Framingham in the U.S. showing higher LDL equals higher risk here.
Right.
And then comes the real powerhouse, right? The meta-analysis stuff.
Yes, the synthesis of the intervention trials. That's the Cholesterol Treatment Trialists Collaboration, or CTT.
That's one that pulls together all the statin trial data?
That's the one. Massive. Data from over 170,000 participants who were actively treated to lower their cholesterol. So it moves beyond just watching people.
It shows cause and effect.
Exactly. It shows the effect of deliberately lowering LDL.
And the key finding from pooling all that data, what did the CTT nail down?
It perfectly validated that linear model we talked about. Their main finding, for every 39 milli-GDL drop in LDL cholesterol,
Okay.
a patient's risk of major cardiovascular events falls by about 20%. 20% reduction for every 39 points down.
That's a significant drop.
It is. But here's the absolutely critical part, the bit that really drives this sub-70 target. The CTT collaboration found absolutely no lower threshold where the benefit stopped. None.
Really? No floor?
No floor. They saw the risk just keep dropping proportionally. Even when LDL levels were pushed way down, like down to 50 milli-GDL, the lower they managed to get it, the safer the participants became.
Okay, if the CTT shows the benefit keeps going down to 50, maybe even lower, why are the standard medical guidelines often set so much higher, like 100, 130? What's the resistance?
Now we're getting to it.
This is where that argument from people like Dr. Michael Greger comes in, right? The whole normal is not safe idea.
Exactly. It's a major disconnect. And Dr. Greger's point, and others who follow this research closely, is that the American normal range you see on your lab report, it's deeply misleading.
How so?
Well, think about how those normal ranges are set. Lab companies basically look at the average results from the population they test.
Okay, makes sense.
But if most people in that population are eating a diet that pretty much guarantees high cholesterol and eventually heart disease, then the average is the average of a sick population.
So normal just means average sick.
You got it. We're aiming for the middle of a group that's already at high risk, not some biologically optimal baseline.
And there's actual data showing how dangerous being in that normal but still too high range can be, isn't there? Wasn't there a study out of UCLA?
Yes. The UCLA heart attack study, really important piece. They looked at patients coming into the hospital having a heart attack, an acute MI.
And what did they find about their LDL levels beforehand?
It was genuinely staggering. 75% of those heart attack patients, 3 out of 4, had LDL levels that were technically below the guideline thresholds at the time.
Wait, hold on. 3/4 of people having a heart attack were supposedly in the safe zone according to the guidelines back then.
75%, yeah. It should be terrifying for anyone looking at their labs.
That really hits home.
It proves the point, right?
Yeah.
The guidelines often lag significantly behind the actual evidence, like the CTT data we just discussed. You shouldn't be comparing ourselves to the average American diet and risk profile.
We should be looking elsewhere.
We should be aiming for the profile of those populations who naturally just sidestep heart disease almost entirely. They're typical LDL levels, like you see in rural Ugandans or traditional Okinawans.
Where are they usually?
Naturally, they sit somewhere between 50 and 70 milli-GDL. That range, 50 to 70, where heart disease is incredibly rare, that should be considered the true optimal baseline, not the American average.
So the big takeaway here for anyone listening is don't just look at your lab report and breathe easy because you're in range compared to everyone else in the U.S. That could be a false sense of security.
A potentially deadly one, yes. You need to benchmark against populations that are actually healthy in terms of heart disease.
Right. Okay, let's pivot then. From understanding the problem and the target to actually doing something about it. If the goal is 70 milli-GDL, maybe even lower, how do you get there? Medication, like statins, is obviously part of the picture for many.
For sure, and often necessary.
But what's the foundation? What's the most powerful tool, according to this body of research?
According to Dr. Dreger, and really the bulk of the nutritional science we reviewed, the primary approach is crystal clear. Diet comes first. Lifestyle changes are consistently cited as the most potent weapon for long-term LDL control.
And what does that diet look like? It's not just vague, eat healthier advice, is it? It's more specific.
Oh yeah, much more specific.
Yeah.
The strategy with the most firepower centers on adopting a whole food, plant-based way of eating.
Meaning
You maximize the foods packed with soluble fiber, like whole grains, beans, lentils, oats, nuts, seeds, fruits, vegetables. Load up on those.
And what do you cut back on or cut out?
Conversely, the strategy involves strictly avoiding or at least drastically reducing 2 main things. Highly processed foods, especially those with refined carbs,
Okay.
and critically, animal fats. Saturated fat and dietary cholesterol from animal products are the biggest drivers of high LDL in the typical Western diet.
That makes sense intuitively. Cut the stuff that raises it, eat the stuff that lowers it. Can you explain the mechanism, though? Why is fiber, soluble fiber, so good at bringing the numbers down?
Yeah, it's actually pretty neat biology. Your liver uses cholesterol to make bile acids, right? Which you need for digestion.
Right.
That bile gets squirted into your digestive tract. Now, when you eat foods rich in soluble fiber, that fiber acts like like a sponge in your gut.
Okay.
It binds onto those bile acids. And because the bile is now stuck to the fiber, it can't get reabsorbed back into your bloodstream, which is what normally happens. Instead, it gets escorted out of the body with the fiber.
So you literally poop out the bile acids.
Pretty much. And because your body just lost that bile, it says, oh, need more bile. To make the new bile, the liver has to pull cholesterol directly out of your bloodstream.
So it lowers your circulating LDL that way.
Exactly. It's like a natural built-in cholesterol disposal system that gets activated when you eat enough soluble fiber.
That's a fantastic explanation of the why behind the plant-based push. Now, we do have to circle back to statins because the CTT data was built on statin trials.
Absolutely. And let's be clear. For people with existing high risk or genetic factors causing high cholesterol, medication is absolutely crucial. It's life-saving. Statins are incredibly effective at lowering risk, and the data fully supports their use when needed. But the consistent message, especially from preventative health advocates, is that while statins are great for managing risk when LDL is high, maximizing the dietary approach gives you this powerful foundational benefit. It addresses the root cause and often lets you reach those truly optimal levels, sometimes pushing numbers even lower than medication alone might achieve, or maybe even reducing the dose needed.
So diet first, medication is a critical tool when required.
That's a good summary, yeah.
This has been a really compelling deep dive into the evidence behind that number, 70 mg/dL. If we were to synthesize the key takeaways for everyone listening.
Go for it.
It seems like the evidence stretching back decades, from seeing near zero heart attacks in the 7-country study to that dose-response relationship in the massive CTT analysis, it just overwhelmingly points toward aiming for an LDL well below 70.
Yeah, the lower the better, essentially. And the core lesson for you listening right now is that achieving truly optimal health might mean you have to actively challenge the status quo, maybe even what you hear in a standard checkup.
Because if you live in a society like the US or UK where heart disease is the #1 killer,
then you have to conclude that the average or normal level of health in that society is, by definition, not actually healthy. It might even be deadly. You need to benchmark yourself against the genuinely healthiest, lowest risk groups on the planet.
And we know from the CTT that the benefit doesn't just stop at 70, it keeps going down.
Right. Which leaves us with a final, maybe provocative thought. Given that the CTT found risk keeps dropping proportionally, way down to 50 mg/dL, maybe even lower, what is the true absolute safest LDL level? Could it be 50, 40? And maybe more importantly, what would it actually take for our society and our medical guidelines to finally catch up and adopt that potentially much lower figure as the new normal?
Something to think about.
Definitely. We really encourage you, look at your own sources, check your latest lab reports, but view them through this new lens. For optimal heart health, the target seems to be aiming for the floor, not just staying below the current ceiling.
I've now listened to this deep dive from Google's Notebook LM 4 times, and I'm shocked. I knew LDL should be below 70, but there's something about this deep dive that I find astonishing, almost unbelievable. I even began to wonder if Google's AI engine was hallucinating. So I sent the transcript of this deep dive to Perplexity, a Google competitor known for its research abilities. And I asked, is it true? Is it exaggerated? Is it hallucinating? And in our next episode, you will hear Perplexity AI's response. Thanks for joining us today, and remember to follow our show so new episodes show up automatically in your podcast app. Please join us again. This is Elton Sherwin. Stay safe and stay healthy.